So I thank the chairman for allowing me to show this case. Okay, so the next case is a valve case, so I've moved beyond the coronaries. So the background, he's 61, so these boys are all ridiculously young, aren't they? So the coronary disease background, he presented with an acute coronary syndrome. He had an angiogram which showed severe 3-vessel coronary artery disease, and so quite rightly, he had a young age bypass operation. His aortic valve was not right either, so he had a tissue AVR at the same time. So he had a bit of a stormy time. He then readmitted with a fast heart rate, got cardioverted, and then that sort of calmed down as well. Prior to his index event, he was actually living life merrily, not thinking he had any problems at all. But since the event, things have rocked a bit. So he had his bypass, he had a tissue AVR, he's had a rhythm disturbance, and he's got hypertension. So talking about the valve, so at the time of the surgery, so Aziz mentioned that there was a possible tiny jet from the LVOT moving somewhere towards the right-hand side, but things looked very steady, and even transthoracic echo showed not much going on, perhaps a tiny jet, sometimes we see those, nothing much. So, okay, so we're carrying on. When he had that rhythm disturbance, okay, a more detailed echocardiogram gets done, the LV's taken a bit of a hit, and there's definitely a fistula. There's a fistula from the LVOT to the right atrium, which is restrictive, which is great news. And he's breathless. He's not recovered as you might want. So he has a number of investigations, and the fistula runs from LVOT right atrium pretty close to the tricuspid valve. And sizing these leaks, because I close a lot of leaks, sizing these leaks is always very difficult. You know, on CT, challenging. On TOE, you have to have a really good TOE operator who can get to exactly where the jet is, and then color flow map it and then measure it. But it's actually often very, very difficult. So he had a bit of fluid taken out of his lung as well. And he's on anticoagulation, dual antiplatelet. He had an acute coronary syndrome. He's on amiodarone to control his heart rhythm. He's on a bit of beta blocker. So he's not just feeling quite right. So he sees Aziz, okay, and the surgery, of course, was complicated. As I said, the readmission we talked about. He had another readmission after that for a week, but he's stabilized out. No more admissions for 6-7 months, but his breathing is not quite right. And so Aziz very kindly asked me to have a look at him. Okay, so what he has is an acquired Gerbode defect. Okay, so the MRI shows that there's a 1.6 to 1 shunt. If you believe that 1.5 is where it becomes relevant, okay. But actually, if it was an ASD, you have a youngish patient, then if the RV is dilated, the RA is dilated, then even a shunt less than 1.5 to 1, you might well consider closing. Certainly if you were 25, I'd close that ASD for sure, because over time, the shunt was likely to increase and the RV is already dilated. So this guy's LV is dilated, the RV is dilated, the grafts are patent, so that's great news. Okay, his hemoglobin is okay. He's not got hemolysis at the moment. Remember, if you have a small hole with a jet going through it at high pressure, then you can get hemolysis as well, but he hasn't got that. So he's got an acquired Gerbode defect, which is proximal to the tricuspid valve. Okay, so I'm sure you guys know the history more than I do. So I described a long time ago, but who cares, because it's the publication that counts. so Gerbode published it a long time afterwards, and so he's the name that we associate with it. There was a big series published in 2015 where half of them are iatrogenic fistulas, so post sort of surgical, and very, very rare is it a complication of a myocardial infarction. Infection, of course, endocarditis can put holes anywhere. Okay, so it's difficult to image because it's in such a funny position. So you can just see a flame of color, just proximal to the tricuspid valve. And on this other view here, then you can see that there's a jet that comes out around about there, but imaging is challenging. So I put a still up there to actually show you exactly where it was. And here's another view where I think it becomes a bit more obvious with angulated pictures that there is a leak going on. Again, if you concentrate very carefully, you get the picture above, which shows the jet traipsing along the top of the tricuspid valve, probably. So it's a moderate tricuspid regurgitation, a Gerbode defect, which is reasonable size. Okay, the actual numbers are immaterial, but it's a reasonable size with a significant shunt. So Panel, what are you going to do? I calculate the Euroscore 2 at 3.5%. It's redo surgery. The RV is not so good now. There's a degree of pulmonary hypertension. And he had a slightly stormy time the first time. We could plug it percutaneously, or we could say, look, you haven't even taken some furosemide yet, mate. Why don't you get on some furosemide and let's see how you are? So what is the panel going to choose?
Sorry. Since he had admissions with heart failure, pleural effusion, etc., furosemide, but I will consider the intervention.
Okay, but what intervention would you choose?
If I have an experienced cardiologist like you, who is good at percutaneous devices, the risk is here the conduction bundle versus the prosthetic, bioprosthetic valve. But that up to you. If the cardiologist is not happy to do it, I go for a surgical correction.
David?
So in the initial circumstances, I would definitely put him on furosemide, wait and see, but with a high expectation that he may need something done. But I think I'd be reluctant to jump in if he gets a great response to furosemide, that depressurizes the situation. But if he does need something done, then it should definitely be a percutaneous approach in the first instance, unless an experienced cardiologist said, we can't fix this. But if they said, well, look, we could try at very low risk, and we think there's a 60, 70, 80% chance of fixing it, that's what I'd do.
Okay.
Yeah, I would say if you told me you were confident you could fix it, or pretty confident you could fix it, I would definitely recommend that.
Right, sir? You have a view?
Percutaneous closure first,
Yeah.
and if you fail surgery.
Okay, so the real question...
That's what we do at home.
Yeah, so the real question is, who in the audience actually has access to that sort of technology? It's already we're saying percutaneous closure. This is quite an esoteric hole, okay? It's not even a standard paravalvular leak, it's an esoteric hole. So hands up who has in their unit someone who does this sort of plugging. Okay, so less than half the audience actually has it, okay? And that's probably about average because there's a lot more percutaneous around than there was, okay? And it should be in the hands of one, maybe two cardiologists in each unit because you need to get your experience level up. This is not, I did one 5 years ago, I'm going to do another one. That's insane, okay? But there is a lot of insanity about. So, so this is probably a high-risk operation, already struggling the first time. And but what I don't think we can do, and I disagree with David there, is the furosemide makes any difference to prognosis, okay? His RV is going to progressively get worse. The furosemide is not going to change that. It might hold its symptoms for a little bit, so you don't have to do it next week. You can do it in a month's time. But the RV is going to fail if we leave it alone. And so there is really no medical therapy that's going to hold this guy. He needs to have an intervention, if an intervention is at all possible. If there's no percutaneous option because the hole is that wide and the surgical risk is too high, then that's medical therapy. But until you've proven that there is no option, you have to have something done. Okay, so the literature on plugging, okay, so I published a series of, not Gerbode because I hadn't found one at that stage, but very esoteric holes, not paravalvular leak closure, but holes all over the place in leaflets, I did one LVOT to LA fistula. Okay, so it can be done. The two published ones have used VSD devices post-AVR, one percutaneously, one transapically. Okay, so transapicals are not straightforward procedures. A congenital one with coils and surgery for endocarditis. So I think if you've got endocarditis, I'm not putting a device in there. That's mad, because devices get infected. So endocarditis, the surgeon is definitely king, unless it's burnt out and we're a year down the line. Okay, so how can we do this percutaneous procedure? You can either go from the right atrium to the LVOT, or this is not a mechanical valve, you can go from the LVOT to the right atrium. And that's what I chose, because you can direct your catheter very easily with good imaging. The imaging from the right atrium to the LV on TOE is very difficult. The tricuspid valves are quite difficult to image, and the catheters often will go straight through the tricuspid valve, and you're going to damage the tricuspid valve. Transapical I very rarely do now. I always plan with CT, because the CT will tell you what angle in the cath lab is important, and you have to swing your camera all over the place. Is that a CT? So it'll give you the answer. So in effect, we've got a catheter that I've managed to swing through the hole. So you can see the AVR is around there, and then the catheter's gone through the hole on a wire, and then I'm creating a rail, because I want to deliver my kit from the RA to the LV. So I get a big plug that can plug from the LV side and leave something in the RA side rather than the other way around, okay? Because the pressure will always push the device into the RA. So if my big disc is on the LV side, it doesn't matter because it's not going to go through. So we want it that way around. But create a rail. So we'll carry on. We've created a rail. Okay, I've got my catheter through. But actually, if I leave my wire going all the way up into the aorta, my first bit of device is going to come into the aorta, probably above the aortic valve because there's no space below it. So I then got another wire into the LV so that I can then have my catheter swinging into the LV so I can safely put the plug out. So we've got some beautiful echo pictures from Bushra Rana. And so a plug, you can just about see the first part of the plug there, if you focus around there, coming through. And then the second part of the plug coming out. So you can now see the plug in position, okay, and the amount of leak substantially reduced. And I've avoided the tricuspid valve. It's definitely where it should be. It's in the LVOT going towards the right atrium, just below the valve.